AFib is associated with an increased risk of mortality. There's an increased risk of death. There's an increased risk of stroke. There's an increased risk of heart failure. So it really becomes paramount that you understand what is it that you're dealing with. Every patient is different. Every patient has different risk factors. Every patient is in a different age group. Just throwing medications at patients, escalating those doses is not the answer. I want the patients to be educated. I want them to know about the latest innovations that are out there so that they're not just walking in with all kinds of confusing information off the internet and talking to their physician.
So atrial fibrillation, also known as AFib, is one of the most common heart rhythm conditions in the world. Millions of people are told that they have it, and almost immediately they're handed a prescription or warned about a stroke or told they might need a procedure. But what most patients don't understand is that AFib isn't just one decision. It's a series of decisions. Medication, ablation, devices like Watchman, or sometimes doing less. So, welcome back to Cardiovascular Therapeutics Unplugged, real conversations about heart treatments that change lives. Dr. Mehra, today we're unpacking AFib the way patients actually experience it, not as a diagnosis, but as a very confusing set of choices. So, thank you so much for having this super important conversation and being able to shed some light on AFib and all the complications and complexities that go along with it. How are you doing today?
Thanks, Lela, for once again hosting my podcast. And we just launched the first episode, so I'm very excited to record the second one. And thanks, everyone, for listening. Once again, I'm Dr. Mehra, board-certified interventional cardiologist, and welcome to Cardiovascular Therapeutics. It's great to be here once again speaking about cardiovascular issues. I'd like to put a disclaimer out there once again that everything I talk about here, my personal views based on the guidelines from the various cardiovascular societies. I might mention my affiliation with certain hospitals as well as the things we do in my private practice, but these views are not views of any institution or any company. Please do not take these things on my podcast as medical advice for your personal situation or condition. So these conversations are just meant to educate you, whether you're a patient, whether you're a physician. Please discuss your specific clinical situation with your own cardiologist/provider.
Absolutely. Thank you. That's so important to get that out there. This isn't exactly medical advice, but some education around specifically today, AFib and everything that goes along with it, like we spoke about all the different complexities. So let's start off by talking about when a patient first hears that they have AFib. So what's usually the first thing that maybe is misunderstood about what the diagnosis actually means and what it really entails?
So we talked briefly in the first episode about a patient that came to see me with AFib. Just going back to that story, let's start with a case-based kind of situation. So I recently saw a patient, 65 years old, with diabetes and hypertension, as well as a previous history of a mini stroke, also called a transient ischemic attack, who was found to have new onset atrial fibrillation. She was diagnosed by her primary care physician. She was sent over to me for a consultation, and I could see the look of concern on her face, and not just concern, confusion. So in this scenario, it's imperative for the physician to take some time to explain the disease process to the patient and what exactly this new diagnosis means. One of her first questions to me was, "Hey doc, I've never been to a cardiologist before, and I want to know am I going to die from a stroke?" Which is, before you start treating this patient, you got to make sure that you alleviate their fears and you educate them again on the specific disease process. So a lot of misunderstanding happens about the specific clinical disease process and the treatment when they do not understand their own condition and they're not adequately informed about their clinical situation.
Absolutely. And I think that with AFib, and it's something that I'm not too knowledgeable on, so I'm learning this right now as well. But with what I do know is that AFib seems to really generate a lot more mixed messages than almost perhaps other heart conditions. So why do you think that patients tend to get such different recommendations recommendations, whether it be from medication to procedures to devices, or sometimes even all within such a short period of time?
One of the things we say back in med school and training is that patients don't read the textbook. And honestly, AFib in particular is confusing. It's not just confusing to the patients, it's confusing to the physicians to manage because, again, there's a constant evolution that takes place in the field of cardiology. There's new trials coming out with new data regarding medications and procedures. We've debated about certain things like rate control versus rhythm control and atrial fibrillation for decades. This is still ever changing. It's really important that the providers and the physicians and the cardiologists, they stay up to date with the guidelines so that they are not treating the patients with something that was relevant 5 years ago. Let's talk about the atrial fibrillation basics. Let's talk about what atrial fibrillation is, and I'm going to delve deeper into how to treat it and what the clinical dilemmas are. Let's understand for everyone what AFib is. Atrial fibrillation is one of the most common things that are out there in the field of cardiology as far as arrhythmias are concerned. Approximately 11 million people in the US have atrial fibrillation, and the global prevalence is close to 50 million in 2020. The lifetime risk atrial fibrillation is about 30 to 40% in the population. It continues to grow. Why it is concerning is that AFib is associated with an increased risk of mortality. There's an increased risk of death, there's an increased risk of stroke, there's an increased risk of heart failure, and there's an increased risk of cognitive impairment/dementia with it. There's also an increased risk of heart attacks with it. So it really becomes paramount that you understand what is it that you're dealing with and why is it important to attack it early on and know what needs to be done. So to that effect, I'm going to allude to the American College of Cardiology guidelines that came out in 2023, try to break this down. Number one thing is causes AFib and what is it that puts you at risk of AFib. So, American College of Cardiology identifies multiple validated risk factors. One of the things is age. As you get older, you're more prone to having AFib. If you have hypertension and diabetes and established cardiovascular disease, you're more prone to having it. And then there's certain things like sleep apnea, chronic kidney disease that also increase your risk. Certain other things that you need to think about are obesity, excessive alcohol consumption, high cholesterol levels. These things can definitely increase your risk. So all this AFib burden is multifactorial. So the next step is understanding different stages are for AFib. Have you heard of the different stages at all?
I am not familiar with the different stages. I did some research to learn a little bit more about it prior to today's podcast, but I am not aware of the stages.
So the 2023 classification and staging of atrial fibrillation came together with societies such as American College of Cardiology, American Heart Association, and the Heart Rhythm Society. And it breaks it down into 4 stages of atrial fibrillation evolution. Stage 1 is the patients who have atrial fibrillation associated risk factors such as obesity and hypertension. Stage 2 are the patients who don't have AFib but have signs on EKG of atrial pathology and signs on imaging, such as atrial dilation and things like that. Stage 3 are the people who have paroxysmal atrial fibrillation. Now, what does that mean? Patients might hear their physicians saying that this paroxysmal AFib. It is basically episodes of atrial fibrillation that come and go, and they last less than 7 days. Or in stage 3, you can also have persistent atrial fibrillation, meaning episodes that last greater than 7 days. And stage 4 is permanent AFib. The staging system emphasizes a progressive spectrum of disease that may need to be treated differently at each stage, from prevention to aggressive therapeutic interventions.
Got it. And from a therapeutic standpoint, what are some of the first real decision points in AFib treatment? And what should patients really understand before they commit to any path? And to take that even a step further, vary depending on the different stages?
The treatment of atrial fibrillation is complex, but there are 3 things that physicians as well as patients have to keep in mind when treating atrial fibrillation. Number 1 is stroke prevention. Number 2, rhythm control. Number three is rate control. So those are the three pillars of treating AFib. So we simplify this so that everybody has this in their heads. Now let's talk about the first thing, which is stroke prevention. And people have heard of these drugs that are advertised on television, Xarelto, Eliquis, all these blood thinners. And patients get concerned about taking them. But these very important drugs that are recommended for patients to reduce the risk of stroke. So atrial fibrillation brings with it the increased risk of stroke. What it does is atrial fibrillation is coming from the upper chamber of the heart, the left atrium most commonly. And what it's doing is, instead of pumping like this with every beat, it's doing exactly what the name says. Fibrillating. It's moving around like this. And when it fibrillates like this, blood is kind of just swirling in this upper chamber, left atrium. And anytime blood is not moving, it has an increased risk of clotting. And that's where the stroke comes in. The first place the heart likes to send this clot to is the brain, leading to a stroke. Strokes are devastating, and the first line of treatment is stroke prevention for AFib. So oral anticoagulation comes into the treatment paradigm. The blood thinners that most commonly are used these days, we've got the traditional blood thinner warfarin, which is a vitamin K antagonist that has been around for many, many decades. Then came the newer drugs, the direct-acting oral anticoagulants such as apixaban, rivaroxaban, edoxaban, all these new drugs that came out. These drugs in most patients are recommended over warfarin due to decreased lower bleeding risks. So that's the first step. Aspirin is considered in patients who have a lower risk of a stroke based on their risk factors. It is associated with poor efficacy compared to full anticoagulation with either warfarin or the direct-acting drugs. So that's the first thing that needs to be treated, decreasing the risk of stroke, and anticoagulation should essentially be continued indefinitely once you have risk stratified the patient based on most commonly what's called a CHADS2-VASc risk score. This is based on the patient's risk factors and includes various different things, such as the CHADS2-VASc score essentially stands for congestive heart failure, hypertension, age, diabetes, a previous history of stroke, history of vascular pathology that they might have had. So you risk stratify patient based on that, and then you give them blood thinners such as oral anticoagulants based on that. So that's number one. That's our decreasing the risk of stroke. Number two is what is called rhythm control. And I know that you have a question about rhythm control. Let me start with this. Rhythm control essentially means, what are we doing? When somebody is in AFib, do we want to convert them to normal rhythm or not? And this debate has been ongoing for a long, long time. Most data now suggests that early rhythm control is a very, very efficacious way of treating these patients. Rhythm control can be done two ways: antiarrhythmic drugs or ablation pathways.
And speaking about all these medications, I think that many patients do start with medications when it comes to AFib. But in plain language, what are some medications actually meant to accomplish, and what are their limitations?
The first thing is stroke prevention. Second line of approach is lifestyle and risk factor modification before we jump into medications for patients. These patients need to lose weight. These patients need to exercise. If somebody's smoking, they need to stop that. If somebody's drinking alcohol regularly, which increases their risk of recurrent AFib, they need to reduce their alcohol consumption. If they've got sleep apnea, that needs to be treated. They need to make sure that they're sleeping well. They need to have adequate blood pressure management to decrease their risk of continued AFib or recurrent AFib. Lifestyle and risk factor modification, and just throwing medications at patients, escalating those doses, is not the answer. Also is a very, very important pillar of treatment. Medications are important. So medications come in two big categories. Either it's going to be rhythm control medications or they're rate control medications. Now, early on, patients who are hemodynamically stable, meaning their blood pressure is okay, they're not symptomatic, you can do the stroke prevention with blood thinners, and you can do rate control, which is usually things like beta blockers and calcium channel blockers, something called digoxin, which is used to control the rate. More and more emphasis is placed on rhythm control, and early on, rhythm control strategy has shown benefit. Rhythm control medications are essentially what are called antiarrhythmic drugs. And antiarrhythmic drugs, or there's a variety of antiarrhythmic drugs that can be used in various situations. There are different classes, 1, 2, 3, 4. In patients who have normal heart functions, you can use drugs like amiodarone that people might have heard of, propafenone, dofetilide, or flecainide if they've got normal heart function. But if they've got compromised heart function, then they might just need amiodarone or dofetilide. But you don't want to use drugs like flecainide or propafenone in those patients in general. A rhythm control strategy can be drugs. Next thing, what's called catheter ablation. And that is another way of rhythm issues.
Ablation, I think, is something that sounds intimidating, especially if you're not too familiar with it. How do you explain to patients when ablation is actually a reasonable option and when it may not be the right move just yet?
This has been, again, another confusing of atrial fibrillation management. More and more studies have come out now which advise ablation over just giving escalating doses of rhythm control medications, antiarrhythmics. Catheter ablation is recommended as a first-line therapy who have symptomatic paroxysmal atrial fibrillations to improve their symptoms or to slow progression to a persistent/permanent atrial fibrillation. Catheter ablation has evolved over time, and more patients are candidates for it now. So if somebody has heart failure, their pumping action of the heart, called ejection fraction, being low, you can improve their mortality and heart failure hospitalization rates, referring them to catheter ablation early on. There are different ways that you can do catheter ablation, and we can talk about that as well.
And then speaking a little bit about ablation, I know that there's certain different techniques that you do within your practice. So can you talk to us a little bit about that as well?
Yeah, sure. So catheter ablation has evolved quite a bit over the years. It's performed by electrophysiologists, and we work with our electrophysiology colleagues at Jersey Shore University Medical Center. It's done in the hospital. It's usually a same day or an overnight stay procedure. It is the first line of therapy for symptomatic paroxysmal atrial fibrillation, like I mentioned. And the most common cornerstone ablative strategy is what's called pulmonary vein isolation, or PVI. Most of the atrial fibrillation stems from this area around the pulmonary veins where they drain into the left atrium. What the electrophysiologist does is basically goes in there and creates these tiny short circuits and burns to treat the area where atrial fibrillation might be coming from, and isolates the pulmonary vein as it suggests in its name. There are generally three different energy modalities that have been used. One is called radiofrequency ablation, one is called cryoballoon ablation, and the third one, which is the most common one, and we're doing it locally in our hospitals, is called the pulse field ablation, which is essentially, the latest technique. So I just wanted to mention that. And then, within that, there's obviously different kinds of specific things that electrophysiologists perform, but these are the different strategies that are used to perform atrial fibrillation ablation.
And then you touched on how a lot of AFib conversations can quickly turn into stroke risk. So, how should patients really think about blood thinners versus devices like Watchman, and what factors actually matter in that decision?
Stroke is the biggest, most devastating consequence of atrial fibrillation. These conversations are tough to have with patients. On one hand, they've got the risk of stroke. On the other hand, especially as you get older, there's the risk of bleeding. The CHADS2-VASc scores essentially risk stratify these patients for us. Now, in patients who have a low CHADS2-VASc score, such as 0 or 1, anticoagulation may not be required. In intermediate risk patients who have a score of 2 or above, or higher risk patients who have a higher score, anticoagulation should be considered. And again, a very important shared decision-making process has to be a part of the conversation. In patients who, oral anticoagulation is recommended for, their estimated stroke risk is essentially greater than 2% per year. Now, you can reduce that risk by 60 to 80% compared with placebo. That's why the CHADS2-VASc score is very, very important to risk stratify and then decide on whether you're putting these patients on blood thinners. In patients who have a higher risk of bleeding, or are not candidates in general for anticoagulation, some of the things that have come onto the market are what are called left atrial appendage occluder devices. A lot of people have heard about these devices. You see commercials on TV for devices such as the Watchman device, which is manufactured by Boston Scientific, the company. That is the primary percutaneous left atrial appendage occluder device. It's essentially via catheters into this area of the heart called the left atrial appendage, where the left atrium forms a clot in the setting of atrial fibrillation. So this device was evaluated in multiple clinical trials. Essentially, the original Watchman device demonstrated non-inferiority compared to warfarin for stroke prevention in the Protect AF trial. So that was a very, very important trial that brought this device to the market. There's other trials such as the Prevail trial that provided additional evidence. Subsequently, there's been different iterations of the Watchman device that have come through, such as the Watchman Flex device. There's other devices on the market. There's another device called the Amulet device, which is another left atrial appendage device by a company called Abbott, which is a second FDA-approved device. So those devices basically have been compared to warfarin, and they've been compared to direct-acting oral anticoagulants in trials, and they've shown essentially non-inferiority to blood thinners. So they're a consideration in reducing the risk of stroke in atrial fibrillation.
In terms of devices and things like that you spoke about, I know that that differs from other times where patients may be told to do a little bit less and may not need a device. So, are there situations in AFib where the best decision is actually not to escalate treatment? If so, why is that often really hard for patients to hear and really understand?
AFib, said at the beginning of this podcast, is a confusing issue. You can't just, and I also said the patient doesn't read the textbook. Every patient is different. Every patient has different risk factors. Every patient is in a different age group. Individualized AFib treatment is the answer. And that requires a comprehensive, stage-based approach that integrates stroke prevention, symptom control, and risk factor modification tailored to each patient and their clinical profile, and also their preferences. This is a shared decision-making process. Some patients, no matter what their risk is, doc, I'm not going on blood thinners, no matter what you say. I have a relative who died being on blood thinners, so you have to work with them, even though their risk might be high. So you have to individualize the treatment. In some patients who are not candidates for blood thinners or ablation procedures, you might not escalate treatment. So individualizing is key in atrial fibrillation.
Absolutely. And for someone who is listening right now, and it's very complicated, and each person has their own diagnosis essentially with this, but for someone who is listening right now and does have AFib, or maybe was just diagnosed with AFib, what's the one mindset shift that would really help them make better decisions moving forward?
In my first opening podcast episode, I want the patients to be educated. I want them to know about the latest innovations that are out there so that they're not just walking in with all kinds of confusing information off the internet and talking to their physician. They need to be educated. They need to have knowledge of the latest innovations, and they need to be motivated to take part in their own care. What is the mindset? I'm going to give you the basics once again of what you need to know about AFib so that you're armed with it. If you or somebody you know has it, you understand there's a classification and staging to atrial fibrillation. Understand that all this comes from the American College of Cardiology and the Heart Rhythm Society guidelines. The paradigm in AFib treatment, decreasing the risk of stroke, controlling the rhythm, being aware of what the different medications are, being aware of what the catheter ablation strategies are, and having an overall holistic and integrated care framework in place so that you're treating the whole patient and not just an arrhythmia. The number one thing for stroke prevention, again, being aware of what drugs are out there, what direct anticoagulants are out there, what devices such as Watchman or Amulet left atrial appendage occluder devices are out there, rate versus rhythm control strategies, the most common drugs that are used, antiarrhythmic drugs that are used with their toxic profile or side effect profile. You have to know that. You have to understand that sometimes physicians might prefer to just do a rate control strategy versus a rhythm control strategy, and when is it correct? Discuss that with your physicians. Are you the right candidate for an ablation procedure procedure, discuss that with your physician. And the risk factor modifications, that is key. Understanding that eating right, controlling your blood pressure, controlling your cholesterol, not drinking heavily, not smoking, all those things, as well as treating things like sleep apnea, are very, very important to managing atrial fibrillation. So hopefully this is a quick summary of atrial fib in order to just educate the patient, take away some of the confusion that arises from this complex, very common arrhythmia.
Absolutely. Thank you so much for shedding light on this and educating people because that it is one of the most common issues that even, for example, people who may not be aware of certain things, I feel everyone has heard about AFib at some point, and it is something that is so common. I think it's really important to have this conversation and educate patients or educate people who can help someone else who's going through this. So I think that AFib isn't just a rhythm problem, it's a decision problem. And really understanding your options is just as important as treating the condition itself. So, Dr. Mehra, thank you again for really breaking this down in a way that patients can actually understand. And to our listeners, if you have been diagnosed with AFib and felt overwhelmed by the choices in front of you, this conversation was for you and I hope was super helpful. And this is Cardiovascular Therapeutics Unplugged, where real conversations about heart treatments can really change lives. So, thank you again so much, Dr. Mehra, and I can't wait to have the next conversation with you.
Thanks, Layla. See you at the next episode.